Good afternoon, everyone. I would like to thank you for tuning in to today's webinar on COVID-19. My name is Stephanie D'Amiglio. I am the Business Development Coordinator here at Bancroft NeuroRehab. Bancroft NeuroRehab is a premier provider of post-acute neurologic rehabilitation, offering residential and day services as well as outpatient rehabilitation, available both in person and via telehealth at our 3 locations throughout central and southern New Jersey, Mount Laurel, Plainsboro, and Toms River. Bancroft NeuroRehab is a division of Bancroft, provider of programs and services for people with autism, intellectual disability, and other neurological conditions. I would like to extend a special welcome and thank you to our partner and friends at the Brain Injury Alliance of New Jersey for co-presenting this exclusive webinar with us. Our goal for today is that this presentation provides you with valuable knowledge and insight that will benefit you both in the clinical setting as well as with your loved ones. Next, I would like to introduce today's presenters. From Bancroft NeuroRehab, we have Dr. Catherine Murray, Rehab and Health Psychologist, Dr. Carolyn Ticini, Rehabilitation Supervisor, and Teresa Fitzgerald, Clinical Social Worker. From the Brain Injury Alliance of New Jersey, we have Laura Jacobs, Education and Outreach Coordinator and Director of CAMTREC. And now I will turn the presentation over to Dr. Catherine Murray, who is going to get us started today.
Thank you. Good afternoon, everyone, and thank you for attending. Briefly, our disclosures. None of the presenters have anything to disclose. So we'll go through the learning objectives and then we'll get started. After this presentation, you'll be able to describe the neurological sequelae and symptoms associated with COVID-19 infection, understand the proposed rehabilitation recommendations for the neurological effects of COVID-19, understand treatment recommendations for psychological and cognitive effects associated with COVID-19, describe the importance of multidisciplinary teams for caring for the patients in order to treat the diverse presentations of physical, cognitive, or psychological difficulties that could result, and then also learn what community resources are available to patients and family members who have been affected with COVID-19. So briefly, COVID-19 is a coronavirus closely related to SARS, severe acute respiratory syndrome. It can cause severe respiratory illness and may even lead to death. The most common symptom presentation includes fever, cough, dyspnea or difficulty breathing, and bilateral lung infiltrates on imaging. So what do we know about COVID-19 and the brain? Patients with COVID-19 can develop a wide range of neurological effects. I found this categorization useful for thinking about the different neurological effects that could happen. You could have encephalopathy, which is a change in your mental status, confusion or delirium symptoms. You could have inflammatory central nervous system syndromes such as encephalitis or meningitis, strokes, peripheral nervous system disorders such as Guillain-Barré syndrome, or a wide range of other neurological symptoms and manifestations. And this can range from myalgias or muscle pains, headache, dizziness. The loss of taste or smell is considered a neurological symptom, or also seizures. So studies are finding that varying percentages of patients are presenting with a neurological involvement. It may be anywhere between about a third of cases to up to 80% of patients that are reporting at least one or more neurological symptoms. So I'll have next Carolyn take us through the specific pathways that COVID can affect your brain.
So you start to wonder, how does this, generally respiratory illness get into our central nervous system, into our brain? And so there's a lot of variety in how it can impact our neurologic system. We can have direct involvement of attacking our cells, if it attacks your neural cells. And then also secondary involvement with things like some inflammatory syndromes. It causes severe respiratory illness and severe illness, which can have its own sequelae associated with critical illness, such as sepsis, multi-organ failure, and those types of things. We see that individuals who are sedated or vented for periods of time can have deficits as well, even in the domains of cognitive and psychological functioning with those. So on this next slide, we'll just kind of show how, some of the potential mechanisms, because again, this strain of coronavirus is fairly new. So for this what they're thinking of how it might be infiltrating our central nervous system is this direct pathway on the left. The first one is going through the transcribial route, so going right through that nasal epithelium, which is why it's important to make sure that your mask is going over your nose as well as your mouth. Again, going through the axons, and it's actually can interface at those intersynaptic areas and get involved into our peripheral nervous system that way. And then it will spread along nerve roots. Or we can have viral spread through our bloodstream or the lymphatic system. We're seeing that this is capable of crossing the blood-brain barrier. We can see it indirectly impacting through some of these immune-related responses and inflammatory responses. It can cause coagulation dysfunction, so increased clotting is something that we've been seeing in this population. You have obviously that respiratory involvement, so we see hypoxia, lack of oxygen getting to the brain. And then there's also these cardiovascular metabolic syndromes that get involved. We have seen that it can impact the actual cardiac function, and it can also be something that's attenuated in individuals who have diabetes or other metabolic illnesses. So if we think about stroke with this population, what's really interesting is that we see that with this particular strain of coronavirus, it's more likely to cause thrombotic events such as strokes as compared to previous strains of coronavirus, or of course other seasonal influenzas or diseases. In fact, showing the 7.6-fold increase in the odds of stroke for patients who have COVID-19 as compared to those who just have the flu. So certainly part of this, a contributing factor might be baseline cardiovascular disease that we're seeing in about 1 to 6% of individuals who have COVID-19. And we are seeing strokes in individuals who are more in that elderly and have more risk factors. However, there is a subset of individuals who are having stroke as the only symptom or the primary presenting symptom of COVID-19. These are individuals under the age of 50 who oftentimes have no or very limited risk factors. It's also interesting that most strokes that are occurring in folks with COVID-19, they're actually occurring in the hospital. So it's not someone who's at home and has a stroke, they're actually in the hospital when they throw their stroke. And we're seeing these strokes, again, more involved in the larger blood vessels. So like our middle cerebral artery, your internal carotid artery, and the posterior cerebral artery, with the most common vessel involved being the middle cerebral artery. The COVID-19 is associated with this increased clotting factor. So we do see a larger variety of ischemic strokes and thrombotic strokes. However, there are hemorrhagic strokes that are also coming out emerging with COVID-19. So slightly more thrombotic or ischemic strokes. What's interesting about that is we do know from previous literature, again, not COVID specific, but that for individuals who have a thrombotic stroke or ischemic strokes, they tend to have a higher survival rate than a hemorrhagic stroke, but their functional limitations are oftentimes more severe, and they have a poorer functional prognosis compared to the hemorrhagic strokes. When we look at individuals who have COVID-19 related strokes, their strokes do tend to be more severe than individuals who have strokes when they don't have COVID-19. What this means is that their functional outcomes are worse, and there's a higher mortality rate compared to non-COVID-19. And in general, we're seeing the poorest prognosis for those who have increased age and intracerebral hemorrhage in addition. So we'll move on to hypoxic and anoxic injury. These are those injuries that occur when you have a decrease in oxygen or in a hypoxia or anoxia, a complete lack of oxygen getting to the brain. Our brain has a really strong desire to get its oxygen and the other metabolites that travel up there. And we have some areas that are particularly a high need of these substances, and that includes our cerebellum, our hippocampus, basal ganglia, our brainstem, and those watershed areas, which, at the end of your MCA and ACA, PCA, those are kind of very distal ends of your blood vessels. So if you think about someone who has trouble with oxygenating their blood, they have a lung disease, right? And possibly a cardiac component. we might see involvement of these structures as well. So thinking about coordination deficits, memory deficits, and motor deficits. Even in your brainstem, especially that reticular activating system, being really important with arousal as well. So when we think about it with respect to our peripheral nervous system, one of the things that's showing up a bit, and again, these are the work we see in the neuro studies with specific to COVID-19 are very small case studies and case reports, the series that are coming out. But there are some cases of Guillain-Barré and Miller-Fisher syndrome. So Miller-Fisher syndrome is a variant of Guillain-Barré. It's more facial muscle involvement. So with Guillain-Barré, we're seeing that motor and sensory symptoms that occur more from distal to proximal, that stocking glove presentation. Treatment's going to be the same as it would be if it was Guillain-Barré of any other etiology, which is your IVIG or plasmapheresis. But we also see our nerves involved in things like the critical illness polyneuropathy, which you oftentimes see in individuals who have been sick for a long period of time or they spend a lot of time in the ICU. And this can include, again, sensory and motor weaknesses that just really are going to lead to a lot longer recovery time because, as we know, our nerves are regenerating at a very slow rate. And we might also be seeing these critical illness myopathy, so more the muscle involvement. There's a case study that's out there about this young woman at 29 years old. So if you're for the vestibular people that are out there, or dizzy folks, a woman who presented to the ER with severe onset of vertigo and vomiting and generalized fatigue. No other symptoms, no other things suspicious of COVID-19. So they ruled out stroke, but she tested positive for COVID-19. Their treatment was that standard, their antiemetics and meclizine and benzos that you would try for, some of these neuritis things. They treated her for the COVID-19, but what really made the difference was the steroids, which of course are now becoming more standard in some of our treatment for COVID, the medical treatment. But for those of you who are, out in a community setting, keeping an eye that some, this peripheral nerve vestibular presentation was a unique presentation of COVID-19 in this individual. Let's just talk about some general rehab considerations because there's really nothing that's going to be different as you treat someone with COVID-19. We're treating the impairments that we're seeing and have identified some of those neurologic ones that we're seeing more frequently in this population. But what's really important to remember with this population is that although this is a respiratory illness primarily, it does have multi-system involvement. We are seeing involvement of the heart, we're seeing involvement of the liver and the kidneys. All of our systems can be involved. So your rehab plan and your evaluation needs to be comprehensive to assess and treat all of these deficits that might be present. Certainly pulmonary rehab is going to be a big part of what we're doing. So you're going to be doing an assessment of, and this is PTOT speech, all can look at this, but we want to look at the person for dyspnea, that shortness of breath. We want to assess their breathing pattern, their diaphragmatic breathing, and looking at their inspiratory and muscle strength. And from a treatment perspective, we're going to treat these deficits. We're going to work on slow, deep breathing with individuals, trying to get that increased thoracic expansion and maybe doing some mobilizations as needed in order to improve that. We can work on positive expiratory and muscle training and doing airway clearance as needed. Not everyone will need that, but recognizing it might be part of what you do. We also really appreciate that, I'm a PT, so I appreciate that early mobility is really important. We've seen this all over the literature with our critical ill population. So again, same in this case with COVID-19, that we want to get people moving as quick as possible. We want to get them moving. We want to work on balance, range of motion, and then start getting their strength back. But again, we need to monitor their hemodynamic and their respiratory responses to activity. There is some work out there looking at the return to exercise, and they're saying that exercise is not recommended until the person is 7 days symptom-free. So symptom-free at 7 days, and then actually 7 days beyond that, you're working your way back into your competitive return to play guidelines. This may change if we're looking at someone, though, who has more cardiac involvement. So you're going to be working with your medical team to make sure that there's no myopathy or cardiomyopathies or things that may give you a little bit more pause in pushing the person's recovery. Occupational therapy will also be working on retraining for ADLs and IADLs and working on some of those cognitive impairments as they present and impact function. Our speech therapists, they can work on dysphagia and voice therapy. voice training. Some of these folks will have been trached and vented. And we can work on communication and cognitive impairments. We're going to spend a lot of time talking about some of the cognitive deficits next. For the PTs, our organization did a phenomenal job of working with a large not disciplinary, but trans group process. So the Physical Therapy, American Physical Therapy Association has groups, and they have collaboration from our neurologic section, our orthopedic section, our sports section, our cardiovascular, acute care, and they came up with these core outcome measures that they recommended for use with throughout the continuum with individuals with COVID-19. And those outcome measures that they recommend for use screen cognition with like the SLUMS, the St. Louis, a quality of life scale, looking at strength. They have a function scale, and also looking at endurance. So their recommendation is to look at these measures regardless of the setting that you're in throughout the continuum, tracking these outcome measures in individuals with COVID-19. They also created a really nice algorithm that's available for you to take a look at. And you do not have to be a member, I don't believe, in order to have access to this materials. So we appreciate their work that they did. That was a real lifesaver there. So the last thing that I want to talk about is this other subset of patients who have COVID-19, and again, it's called long COVID-19. So you may have heard about people calling long COVID-19, chronic COVID-19, long haulers. This is an area that is really continuing to emerge as far as what we know. The definition is not really set in general. They're saying that these people, we'll call it chronic COVID-19 if their symptoms are lasting beyond 12 weeks from their initial injury or initial illness. But what they're seeing is that individuals who have had oftentimes a more relatively mild case of COVID-19, so these guys are not been hospitalized, are still having long-term symptoms several weeks and months following that initial injury, or initial illness rather. And we're seeing most of the studies are actually landing somewhere around 10% of individuals. They've divided them up, and there's a group that has the more serious sequelae group, so this is the thromboembolic group, or this non-specific group. And with that non-specific group, they're seeing things like this cough, this low-grade fever, fatigue, malaise, and these symptoms are things that might relapse and remit. So you have symptoms, you feel better. They're testing negative for COVID, but they feel lousy. And what it's doing is it's resulting in them feeling short of breath, very tired, and it's even causing some cognitive fog and cognitive fatigue issues as well. And as you can imagine, there's a component of that depression that plays in there because these people don't feel well. And it's not sure exactly why, who is ending up with this. Some of the thought is that it might be more from an increased inflammatory response. So people that may have had some susceptibility to that earlier or prior to their injury might be susceptible, but it's not sure exactly who is ending up with these long-term symptoms. But there's even work showing that up to 2/3 of adults have complaints up to 2 months following their original symptom onset. So this is a real phenomenon that's out there. And I think was it on like Sunday morning or something, even this weekend, they did a piece on it, that there's a whole group that's studying this, I think up in New York. Not updated references or whatever on that, but yeah, I mean, this stuff is still emerging. So I'm going to pass it over to spend a little bit more time talking about the cognitive and psychological pieces.
I wanted to talk about the individuals who, Carolyn had mentioned those who had it maybe less severely, but the ones who do have a severe case and end up in the hospital. And there is a previously studied phenomenon of post-intensive care syndrome that happens to ICU admitted patients, and they can present with a cluster of physical and cognitive and psychological deficits that will persist after the discharge from the hospital. So they may have pain, impaired pulmonary function. Again, this is for ICU admissions in general now. Impaired exercise tolerance, neuropathies, muscle weakness, fatigue. They can show cognitive symptoms like problems with their attention or memory or executive functioning, psychomotor skills, and they're having psychological symptoms that may be post-traumatic stress from their ICU experience or anxiety or depression. And the studies that have been done on post-intensive care syndrome have delineated several risk factors for developing this condition. It's associated with a longer ICU stay, the need for mechanical ventilation or a long duration of ventilation, use of sedation, older age in the patient, and experiencing hypoxia or hypotension, glucose dysregulation or sepsis during their stay, isolation, and also if the patient had premorbid either physical health or mental health conditions. So we do want to think of our individuals that we treat with brain injury or other neurological conditions that they might be more at risk to be affected. And looking at these risk factors that have been identified, COVID-19 really checks a lot of the boxes for having a longer stay, needing ventilation and sedation. The patients of older age tend to have it more severely. And of course, they're very isolated by necessity. They have to be extremely isolated during their treatment. We also look to studies that have been done already on SARS and also MERS, which is the Middle East Respiratory Syndrome, to learn what we might be able to expect about cognitive symptoms from COVID-19 in the future as the SARS and MERS studies were able to go out a year or 2 years post-infection. So one study had survivors reporting fatigue, sleep problems, shortness of breath, general reports of decreased mental health and fear and social stigmatization, and that was found at a 1-year follow-up study. So they had found that about 17% of these patients had not been able to return to work within the year after their discharge from the hospital from SARS. And an additional 9% had returned to work, but at a lower level of employment than they had before. And about 1/3 of them had reported that they utilized mental health treatment in their year since discharge from the hospitals. So with looking more specifically what cognitive and psychological symptoms are being reported, they were showing post-traumatic symptoms, panic, depression, and obsessive compulsive symptoms that were persisting even a year or 2 years after the infection. And when you think about it too, the obsessive compulsive symptoms do make sense in this climate of you constantly have to wash your hands, be careful where you go, germs are dangerous. If people were at all predisposed to some OCD traits, it's definitely going to make things worse now. So what cognitive changes could we expect? We should probably be prepared for all aspects of the cognition to be involved, from your attention and memory to visual spatial abilities, executive functioning, which is a broad term for planning and figuring out, integrating information, being able to make future predictions, being able, things like keeping your appointments, keeping your checkbook, all those day-to-day functionings that we need. And again, prior studies that have looked back on other severe respiratory illness survivors have found that anywhere from 70 to 100% were reporting cognitive impairment when they were discharged from the hospital. And then when they were followed up, still 46 to 80 were showing some deficits at 1 year, and 20% were still showing deficits at 5 years. So there may be very long-term cognitive effects that we will have to account for. So then we see that the cognitive and psychological impacts of COVID-19 are likely to be diverse and to require this individualized assessment and treatment plan. There's going to likely be a wide range depending on if the patient had those neurologic effects we were talking about before, whether they had a stroke in a certain region of the brain, or whether it was general inflammation, or maybe they had a mild case, but they're just reporting these brain fog symptoms. There'll likely be many different profiles and not a one-size-fits-all. But we can start to expect that we may see attention and memory problems, executive functioning and information processing deficits, and also to be prepared for the psychological impacts with anxiety, depression, post-traumatic stress. As we've mentioned a few times, people are just complaining of this vague brain fog that's been hard to quantify. And folks may have difficulty returning to school or work even after they've recovered. That was seen in the SARS studies, and also if they were hospitalized in the post-intensive care syndrome studies, if people were in the ICU for any reason and developed this, they had difficulty then returning to work within the year after their discharge. So that brings me to the role of neuropsychology in the post-COVID care treatment plan. So neuropsychological assessment can play an important role. The evaluation can provide the individualized assessment of the specific cognitive deficits or emotional factors that are going on for that patient. Then the treatment recommendations can be tailored to their cognitive strengths and weaknesses. Also, this could really aid in communication about those cognitive deficits or the psychological impacts to the rest of the treatment team or to the caregivers. We were talking about how this is primarily thought of as a lung problem, a respiratory problem. So caregivers may be confused. They may say, well, my loved one came home from the hospital. Why do they seem to not remember what we've been talking about? Or I'm still doing a lot of their daily tasks for them, even after they're home, and this should have gotten better. So to be able to communicate what's going on and what they might be able to expect. And then also the evaluation will lead to, or the neuropsychologist can also provide a cognitive treatment or a psychotherapy to help the patients with coping with these changes in their cognition or the psychological impacts of the disease. And then generally what you can expect with a neuropsychological evaluation, this will take a look at your full biopsychosocial history with interview or interview with your loved ones, referring to doctors, a full record review. And then there'll be measures of alertness and orientation, looking at the patient's attention, working memory, processing speed, abilities, their language skills, their visual perceptual skills, fine motor skills, looking at their memory and learning abilities, executive functioning, and also tying in those emotional factors and the psychological impacts that they're experiencing as well. So then the evaluation will include the diagnosis and recommendations for further treatment. So then to take us through our further psychological treatments, I'll now pass it off to Terry.
Great, thanks. So when it comes to the mental health impacts of COVID-19, due to the newness of the disease, the delayed or the chronic effects of this pandemic are just starting to come to light now, particularly on mental health. So will not be fully appreciated for several years to come. But although old age and pre-existing physical, cognitive, and psychological impairments are risk factors, we can see that even those without such conditions are at risk for long-lasting sequelae. And unfortunately, these secondary factors can be much longer lasting than the virus itself. So differentiating the cognitive and the psychological sequelae is very difficult for clinicians. Attempting to determine the etiology of cognitive impairments in survivors can be difficult for therapists to determine, in both medical factors and psychological factors can both contribute to cognitive delays. Therefore, it is important to look at both cognitive and psychological factors when discussing treatment options. Another thing to be aware of is the medications involved in treatment. Carolyn disclosed that steroids are being used very often in the treatment of COVID-19. And what we know about corticosteroids, especially like dexamethasone, is that they can have some psychological impacts. They've been seen to have sleep disturbances, delirium, hypomania, and also sometimes psychosis. And these effects do typically resolve upon termination of the medication. So if symptoms of these psychological disorders are showing up and the patient is on a steroid, it's important to try and determine whether the steroid could be the cause of this, or it could be something else that's going on. So when it comes to the psychological symptoms, as Dr. Murray had mentioned, we can use past pandemics such as SARS and Middle East respiratory syndrome, as well as the influenza pandemics, to look at what information we can gather in terms of the medical and mental health issues. with these viruses and use this to prepare for what we're going to be facing with COVID-19. Many of the complaints that have been noted and the psychological factors we are dealing with are acute stress, loneliness, depression, anxiety, sleep dysfunction, and symptoms associated with OCD, as well as PTSD. And a 2009 study found that survivors of SARS were clinically diagnosed with PTSD at a rate of 54%, depression with 39%, and OCD with 15.6% at the 31 to 50 month post-infection mark. And this was a dramatic increase from their pre-infection prevalence of any psychiatric diagnosis. So individuals with a pre-existing mental health disorder may also be especially vulnerable to distress during this pandemic. In terms of the probable causes for this interconnection, we have reduced access to family members, pleasurable activities, and also rehabilitation and care that they were receiving previously to the quarantine may result in anxiety and demoralization in people. Contact isolation has been associated with increased symptoms of depression and anxiety, as well as fear and hostility towards medical providers, also government officials who are laying down regulations, and others promoting restrictions of social interactions. Depression and anxiety have been linked to constant media coverage emphasizing high death rates, stigma due to community or family members blaming survivors for the spread of illness, or the thought that someone who contracts COVID-19 is not being careful. Also the fear of infecting loved ones, death of close family members, and having survivor's guilt. The financial burden is also a big factor, and this can be worsened by direct or indirect healthcare costs and the loss of income of patients' caregivers, adding to anxiety and depression. The reports of increasing domestic and child abuse are being reported globally during this pandemic, and reports of suspected isolated cases may suffer from anxiety due to uncertainty about their own health status and develop obsessive compulsive symptoms. And that goes along with what Dr. Murray was talking about with repeated temperature checks and sterilization. Imposed mass quarantine applied by nationwide lockdown programs can produce mass hysteria and distress due to factors like a sense of getting cornered and a loss of control. And for people bereaved from the death of dear friends, colleagues, and loved ones due to COVID-19, the inability to gain closure, to have funerals, to have even just the physical contact of hugs and love and support, this can result in anger, resentment, and psychological trauma and long-term psychiatric symptoms. Post-traumatic stress disorder is a serious mental disorder negatively affecting functioning and social life, and is also marked by 3 types of symptoms. This includes re-experiencing traumatic effect, having like flashbacks and nightmares, emotional numbness and avoidance of activities, and also increased arousal, such as sleeping problems and irritability. Even among those who don't meet full criteria for this, post-traumatic stress symptoms have been associated with functional impairment. So these post-traumatic stress disorder symptoms and even just stress symptoms can be seen in both survivors of COVID-19, those who still have COVID-19, and also in individuals who have not contracted the virus. And given the widespread fear of COVID-19's mortality, the fear of the disease itself, or even having the disease itself, can be experienced as a life-threatening event and may be considered a trauma. Among COVID-19 survivors, the greatest risk of developing post-traumatic stress disorder seems to include individuals with increased risk of developing complications or hospitalization, individuals who are not provided with appropriate health care due to health service overload, or even being resistant to go to the hospital because they're afraid of contacting it there when they might already have it. and also healthcare workers and other professionals who are at risk during the pandemic. Also considering stigmatized groups and individuals experiencing additional mental health problems may have difficulty receiving the care that they need, and thus finding themselves with post-traumatic stress. Another potential cause for post-traumatic stress disorder in COVID-19 survivors is delirium. And in elderly and mechanically ventilated populations, delirium may occur in up to 80% of ICU patients. There is research to suggest that the recall of distressing ICU delusional memories is actually more what's contributing to that trauma than the actual delirium itself. So it's remembering it and the flashbacks that are causing the patient currently to experience trauma and not having actually gone through it. Family members of survivors may also suffer from post-traumatic stress disorder, anxiety, and depression, and they may have difficulty managing their new roles as caregivers. Also, frontline healthcare workers are strongly at risk for post-traumatic stress disorder because of complicated work procedures, the heavy caseload, the stringent restrictions that keep psychiatrists, psychologists, and social workers out of isolation wards due to the concern of them contracting the disease. They often will then become the main personnel providing psychological interventions to patients and not have the background and education to do so. Just to add a little side note to this, because we are seeing such a strong overlap of medical, cognitive, and psychological symptoms among COVID patients, it is important for us as clinicians to keep our communications and our minds open to one another to address these factors collaboratively. There does still exist a stigma regarding mental health, and it's important to our general health. Even if you take note of the COVID-19 task force that has recently been created by Biden and Harris, they have 14 individuals who all have impressive credentials, but not one psychiatrist, psychologist, or social worker is in that group. So next to cover COVID-19 and suicide. Suicidality among individuals who had COVID-19 may be related to psychological factors, including learning of their diagnosis and being fearful of what's to come, distress related to symptoms of the disease, and stress related to the treatment. COVID-19 survivors should be regarded as individuals at elevated risk for suicide. The single most significant predictor of suicide is the presence of depression. Recovered COVID-19 patients need to be screened for depression and suicidality. And of note, post-traumatic stress disorder individuals are 2 to 5 times more at risk of suicidal ideation, suicide attempts, and death by suicide. Sleep dysfunction that has been noted is another complication factor considering its relationship to anxiety, depression, and post-traumatic stress. Poor sleep is a common complaint among survivors of ICU treatments, and sleep problems can persist even after discharge. Thus, sleep dysfunction can be expected to be seen in a subset of survivors of COVID-19 treated in the ICU. Decreased sleep quality has also been documented in non-patients during the COVID-19 lockdowns associated with stress and anxiety. And sleep complaints are also noted due to a change of routine and lack of activity during the days during quarantine. So increased sleep during the day can create decreased sleep at night, and we're seeing that in individuals who are now home and not out for their daily activities, their programs, and their jobs, that their sleep schedule is getting very disrupted. So treatments. Regarding psychotherapy, providing your clients with access to safety, looking at is the individual at risk of self-harm or harming others, identify their supports, refer to psychiatry if needed for medication management, Cognitive rehabilitation and lifestyle changes may be warranted. So linking patients to social and mental health services and counsel patients to seek professional help assistance when needed. So that involves referral to other areas of concern, OT, PT, to speech, to psych, and even if someone is having difficulty in their job due to the factors like those that were mentioned with brain fog, can DVR get involved? Provide evidence-based therapeutic interventions. So typically those that are used with depression, anxiety, cognitive behavioral therapy, acceptance and commitment therapy, motivational interviewing. Also, CBT or cognitive processing therapy has been found to be very effective in post-traumatic stress disorder patients. While quarantine is anxiety producing itself, for many it provides a sense of control over their health. So as long as I am not in contact with others, I am safe. But as people are expected to re-enter workspaces and resume certain activities with the knowledge that the virus is still out there and there are individuals engaging in unsafe practices, this can be very anxiety producing. So re-entry should be something that is discussed and eased into when possible during counseling. Since almost every element of COVID-19 outbreak is also questioned, there is so much uncertainty and confusion that anxiety is almost an expected occurrence. So help yourself and others by focusing on what your core beliefs are and what is within your control. What are your values and how do you want to be seen in handling this time of high anxiety and depression and uncertainty? Encourage person-served or outpatient clients that participation in their rehab and in-house programs may provide a sense of normalcy and control over their recovery. Assist them with maintaining a routine and providing structure during their day. Connect outpatient clients with resources such as online support groups. There's many online support groups now, and in addition, there's also many information seminars going on that are free, which is a wonderful thing that we now have more at our ability to gain information. The use of teleconferencing has also come in handy in still being able to provide services to those who are fearful of coming in person. And normalize by providing information about usual reactions to this kind of stress and pointing out that people can and do manage even in the midst of dire circumstances. Normalization of psychiatric symptoms in survivors of ICU treatments may be an important first step, that much of what you're going through is normal and that there are things that can be done. That reassurance can be very important in dealing with these psychological factors. And I just included this slide of something that I have found to be useful with my clients. Russ Harris, who is the author of The Happiness Trap, and he deals with acceptance and commitment therapy. He created this acronym FACE COVID to help people cope, thinking about, the F being focused on what's in your control, the attitude and how you follow recommendations, acknowledging your thoughts and feelings. So not with judgment, just with observation. Coming back to your body scans, progressive muscle relaxation, being aware of your breathing. Engage in what you're doing. So those grounding techniques to bring you to the present of what is in your control and where your attention could be, and especially engaging in pleasurable activities during this time. Committed action. What are the most effective ways to spend time and how can you help? Opening up is making rooms for difficult feelings and being also kind to yourself. Your values, as I mentioned, how do you want to be seen in handling this crisis, and identifying your resources. Also, the D being to disinfect and distance physically, which is something that people have a hard time doing, especially for such a long period of time, that distancing socially. So finding ways to be social while still maintaining these safety guidelines. So now I will hand the presentation over to Laura.
As mentioned earlier, my name is Laura Jacobs. I'm the Education and Outreach Coordinator for the Brain Injury Alliance of New Jersey. The Brain Injury Alliance of New Jersey was founded in 1981 by family members and friends of people with brain injury. The Alliance is a statewide nonprofit organization dedicated to improving the quality of life for anyone impacted by brain injury by providing support, advocacy, and information while promoting brain injury prevention also. So from all of the great information that we've just been listening to, we know that those we work with, there are many indirect effects from brain injury at any time, and especially now during this pandemic. As Teresa mentioned, concerns have been brought to us of those in isolation, anxiety of getting sick or bringing that sickness home to their family members, addiction, restrictions, especially changes in their routines, limited access to programs such as day programs, doctors, DVRS, and the list goes on and on. Some don't have the technology to connect, while others with brain injury cannot stay on the screen for long periods of time because of pain, headaches. So with all of this happening, I wanted to explain some of our programs and services that are available to you throughout New Jersey and how we have responded to the challenges with those that we work with that now face direct and indirect effects through this pandemic. BIANJ's programs, services can be categorized under 4 different departments, which we will talk about in these next few slides. So the first is our direct services. The first 2 you see, the family support and support coordination, are funded through the state. And then we have a privately funded CARES program for children and for adults. And it depends on the need, type of injury, age, where the individual falls under these different management services, focusing on collaborating to assess current needs and develop a plan to achieve the greatest potential for quality of life. The Information and Resources Helpline is available Monday through Friday, 9 a.m. to 5 p.m. And we also have a live chat option available on our website. For this period where we are working hybrid from the office, the helpline number has changed. The number we are using now is right up on the screen, 732-783-6172. You can also go onto our website, bianj.org, to locate that helpline, or you can chat live like I had mentioned before. The support groups are amazing. We have support groups throughout the state, currently in at least 16 counties. These are a great resource for individuals and families affected by brain injury, but it's also a great opportunity for people to come together to network with other people that really have that knowledge to help. Also connects people one to the other. And it also gives people the chance to give back. So support groups are a great tool. Sometimes they also have guest speakers that come out to the meetings as well. But we know that during this pandemic, we're not able to come together live in person. So the Brain Injury Alliance has come up with virtual support groups. And I know Teresa was just talking about that those are very important. Every week on Wednesday at 11 a.m., we provide a virtual support group, and they alternate. One week will be for individuals that have sustained a brain injury, and then the following week will be for the caregivers, because it's just as important for the caregivers to get support to make sure that their foundation is strong, to keep the whole family together and strong. And then we come up to Camp Trek, which I hold dear to my heart since I am the director of Camp Trek. This is a week-long residential camp program. It provides a week of independence, recreation, and socialization for adults with brain injury, while their caregivers enjoy a week of respite. Trek is designed to serve individuals with a diagnosis of brain injury that are 18 years or older and reside in New Jersey. And also, because of COVID, we offered camp this year virtually, in which we helped each other with technical support. The Brain Injury Alliance even lent out iPad to a camper so that they would be able to participate with us and attend. We have also created now every other month a virtual meeting for the campers to come together and continue with that socialization and support. Our next one will be on the 17th for our holiday virtual get-together. The mission of the Council for the Head Injured Community is to champion and publicize the advocacy, rights, and needs of people who have survived a brain injury. Since the pandemic began, they have met at least 13, I believe it's up to 15 times, to understand the needs and concerns and to address these needs and concerns. Speakers have presented on topics such as preparing for emergencies, relationships, disability rights, voting access. We've had presenters come in from DDS and the Senate. So the next slide, I'm going to talk about education. The Brain Injury Alliance offers a variety of free webinars and workshops regarding brain injury. All of the webinars are archived and can be found on our website, again, free to you. Since the pandemic began, we have had workshops put together for seniors on how to keep safe, because now that we're in the home and that's where most falls occur. So safe within the home from falling and staying connected with technology, because the senior centers are closed, so they can still connect with friends and with family, and how to do that. On how caregivers can advocate, substance abuse, domestic violence, and brain injury. All of these topics are available, emergency preparedness, and so much more. If you are interested in having us come out for this free traveling workshops being done now virtually, you can learn more about these topics posted online on the website. Or you can call me. I will be giving you my contact information in the next few slides. At this time, they are being provided virtually. We have, as you can see up on the screen, we have regional trainings for health and human service professionals. The topic changes every year. We have a different topic. We provide an annual professional seminar once a year. These provide CEUs. There is a slight fee for this, but it's a full day of training in which you can receive up to 5 CEUs. And then a family fest. And this is for the families, again, to come together. It gives them an opportunity for those living with brain injury and their caregivers to network, learn about different resources available to them, socialize, and we always have fun when we come together. So any of these topics, you can come onto our website and sign up for the monthly e-news, and we let you know what's going on, what's coming up, even with Bancroft when we work with them. So we let you know what's coming up, and you only get that once a month. So on the next slide, we talk about, so we like to make sure that we're out there in the schools and teaching, and that you can recognize and work with individuals. But a big part of the Brain Injury Alliance is also prevention. So we go throughout the state to try to prevent from brain injuries from ever occurring to begin with, as we were talking about with the masks, keeping your hands clean when we're out in the community. We work with high school students on how to decrease distracted driving. This is a great program called You Got Brains Champion Schools. We provide a stipend to them. It gives the students and the staff of New Jersey high schools to develop and execute campaigns to address and promote teen driving safety in their communities. And it's evidence-based program, so it does keep our teenagers safe and in turn our community. We have childhood safety presentations regarding pedestrian, bike helmet, and passenger safety, and distracted driving website, jerseydrives.com. So if any of you have your children about to drive, this is a great site to go to try to lower that anxiety you may be having. We have Share the Road campaign. This is the easiest thing you can do to make a change in New Jersey. All you have to do is go onto the website and take a pledge to drive safe on the road. And this is to increase awareness about driving safely on the road, whether you're a driver, motorcycle, a cyclist, to come together and be safe on the road. And by simply taking this pledge, you're agreeing to be a cautious, careful driver, respect the rules of the road, and look out for others. And by doing that and taking that pledge, you also get a chance to win gift cards up to 12 months. We choose the last Friday of the month, someone that has taken the pledge over that year, and you can receive gift cards. So that's always a good thing. And our concussion campaign, because there's so much misinformation regarding concussion, and whether it's children, grandchildren, friends, if you're teachers with students or some of your clients, we want you to be able to look and find reliable information that you can always reach out to the Alliance for that. We've been working with concussion since 2005 with the Concussion in Youth Sports Steering Committee, and we stay up to date on current research findings by reputable sources. and then seniors and falls, known as Heads Up Seniors. The purpose of this workshop is to increase independence and decrease falls among our senior population, as well as discuss driving and pedestrian safety tips. And then advocacy. We strive to advance a public policy agenda to fulfill our vision of a world where all individuals with brain injury and their caregivers maximize their quality of life. The consequences of all unavoidable brain injuries are minimized, and all preventable brain injuries are prevented altogether. So this last slide just shows that how you can connect with us. You can stay connected through the Alliance through the following social media, liking our Facebook page, or visiting our website for these free resources. We're currently in the process of updating sportsconcussion.com, but you can check that website out for concussion information. And you can see right there on the bottom, that's my email address, ljacobs@bianj.org. You can reach out to me. You can reach out to our helpline if you have any concerns, questions, or you want any of these resources. And last but not least, I wanted to thank Bancroft for having us on today and join with them on this very much needed and important topic.
I wanted to let you know about several ways to connect with Bancroft NeuroRehab. You can call us to make a referral. The number's up there. It's 844-234-8387. And you can also find us on Facebook, Twitter, Instagram, and our website, bancroftneurorehab.org.
So this concludes our presentation and our Q&A session. On behalf of Bancroft NeuroRehab and the Brain Injury Alliance of New Jersey, I would like to thank you for joining today's presentation.